Hello, everyone. Welcome to Digital Transformation, COVID-19 and Beyond. Both the chat and Q&A features will be available throughout the session, so please ask questions, make comments, and stay engaged.
Great. Thank you so much for joining us. This is Dr. Helen Burston, the CEO of the Council of Medical Specialty Societies. You are here for our final take-home plenary, where we think about combining how all these tracks come together. As part of our welcome, we just want to remind you, feel free to join the conversation using hashtag DigitalMed2020. You can use the Q&A and chat functions on the platform to ask questions, engage in discussions. And before we launch, I just want to turn to Todd Ibrahim, the Executive Vice President of the American Society of Nephrology, who's been the president of CMSS this year, to just say a welcome, and then we'll get launched.
Thanks, Helen. And thank you for just organizing just an absolutely outstanding meeting. I look forward to going back and rewatching watching the sessions I missed and rewatching the ones that I attended. And I'm really excited for this closing fireside chat. I think everyone's in for really just a wonderful discussion. So to thank you and Julia and the rest of the CMSS team for getting us to this point. It's late on a Friday, and we're excited for this final discussion. So thank you.
Great. Thanks so much, Todd. So thanks to the three of you for agreeing to do this. We're really excited to have these sort of big picture thinking at the end of the day, after a couple of days of just remarkable sessions around things like clinical registries, privacy, unintended consequences, dissemination of research, and just so many more topics. So I'm going to introduce each of you, and then as we discussed, I'm going to turn to each of you to give a brief sort of sense of from where you sit, what has really been the challenges encountered in the last 8 months of the pandemic that really present unique and important opportunities for digital transformation for the future. So I'll introduce each of you and then turn to each of you in turn. So first, delighted to introduce Dr. Nakela Cook, I guess still relatively new, Executive Director at PCORI. And thank you again. PCORI was also a sponsor of our meeting here today. Cardiologist, health services researcher, years of experience as a senior scientific officer and chief of staff at NHLBI. We're delighted to have her join us here today, and brings a obviously really strong focus on what could happen in terms of the digital transformation of research, but also really importantly, as your staff did a great job yesterday on a session of, it's not enough to have research if we can't think about how we disseminate it and get it into practice. We've also got Bob Wachter, professor and chair of the Department of Medicine at UCSF, and he's the Holly Smith Distinguished Professor in Science and Medicine and the Endowed Chair in Hospital Medicine, and often credited with being the father, in fact, of hospital medicine. And past president, obviously, of SHM, one of our member societies, and somebody who all of us have come to rely on in this pandemic for a voice of reason as we look to what's going on with COVID, and all of us who excitedly look to see your long tweets of what's happening in the world and at UCSF. And then last and certainly not least, Michael Howell, who is the principal scientist at Google, where he's a chief clinical strategist in healthcare at Google Brain. He's a critical care physician and a healthcare delivery scientist, and like myself, comes out of the world of quality and was the former chief quality officer at the University of Chicago. So, that really unique blend of thinking about what happens in the health system day to day to make care better, and then having this incredible background around what's possible with the digital transformation of data, research, and education. So I already quoted you today once, Michael, in my last session or 2 sessions ago, and I love your comment about AI. It's math, not magic, which I use a lot. So I quoted you and you weren't even there. So let's just start the conversation. Again, this is intended to be fairly informal. We just would love to get your sense of what you think makes what you've seen in the last 8 months that gives you hope for what is really the digital transformation that can stick with us. And I think we thought we'd start with you, Dr. Cook.
Well, thank you so much, Helen. And it's a pleasure to be here and glad to be here with the other panelists. And as you mentioned, I began my tenure at PCORI about 6 months ago, so entered an organization that is really aligned with my vision of thinking about how we promote research that's patient-centered and engages all parties to contribute towards shared goals. But little did I know I'd be joining the organization in the midst of a pandemic and thinking about several of the challenges that we're facing the research enterprise in general and the public health infrastructure as well. And we certainly have witnessed those cracks in our healthcare enterprise as well as the research infrastructure as we deal with issues of COVID-19. And I think some of what we've seen has been really a learning opportunity in the midst of what has really been a devastating crisis. And some of that learning comes from the opportunities that we've seen in terms of communication that's occurring across healthcare sectors and research sectors, organization and coordination that was previously really unheard of, and then as well as hospital systems and other academic centers coming together in ways that were not previously imagined. And we have natural experiments that are just occurring all around us. And it's been really impressive to see the transitions of care from predominantly in-person care to a real adoption of telehealth and other approaches to delivering care in a virtual setting, as well as the fact that I think several of our organizations have begun to share data and to share information in ways that demonstrate really knowledge that's needed on the front lines in terms of understanding variations in practice patterns and what's working and not working, and leveraging the data and technology within healthcare systems to really promote that type of information sharing. And so I think that one of the things I would say in terms of how I see opportunities from what we're learning in this pandemic is that one of the core purpose or principles for PCORI is to really generate evidence that's going to help people make better informed decisions, as well as ensure that we can expedite access to that evidence. And we've had to figure out how we do that in a rapid cycle in this environment, focusing on the engagement that it's going to take with patients and communities and partners to make that happen, as well as thinking about the areas of learning that are around telehealth or even the stark disparities we're seeing in COVID-19 and how we can leverage data towards evidence that can inform practice in those settings. So those are some of the things that I'd be excited to talk more about, including some of the learnings we've had from a portfolio focused in telehealth and disparities that we're now seeing implications for work right now related to COVID-19, but I think also ways that it's accelerating the potential and possibilities even beyond the pandemic. You're on mute, Helen.
And you know, it wouldn't be the end of the day if I wasn't on mute at least once. I think I've avoided that most of today. I do love that potential impossibilities. That's in many ways, I think the theme we're hearing a lot of things we could not have imagined are now possible. So, Bob, what's your take on this? What have you seen from where you sit as running a health, running a department in a large health system in a big city?
Well, it's hard to sum up in 5 minutes. There's so much that's gone on, but let me try a few general themes. First of all, we've been extraordinarily fortunate in San Francisco. We've had the lightest hit of any of the 20 biggest cities in the country. And I don't think that is a coincidence or weather or luck. I actually think that what we have demonstrated is what happens when you have good leadership of both political types and actually the corporate leadership, including Michael's company, and good citizenship. And the citizens of San Francisco have followed the science. And what we've demonstrated is we've had 145 deaths in the city of San Francisco since this started. And if you extrapolated our per capita death rate to the rest of the country, we'd have about 55,000 deaths, not 220,000. So I feel very fortunate about that. I think one of the lessons, of course, is what is the shocking political response and what we've learned about the commingling of politics and science. And that's a real threat that we have to take seriously going forward. One of the quotes I love is from John Barry, who wrote The Great Influenza, a wonderful book about the 1918 pandemic. And Barry, in a New York Times article a few months ago, wrote, "When you mix politics and science, you get politics." And I think that's one of the take-home lessons from this. And we have to do a better job in communicating to people and gaining their trust, because one of the things we've learned from this pandemic is if people don't believe the science, they don't do the right thing. And we can't be confident anymore that we are your counselor or a specialty, or we went to here for med school or did residency, or we have an MD or a PhD, and therefore people will listen to us. There's a skill there. And we learned that this is about much more than just medicine or epidemiology or virology or immunology. There's a lot of this that's about sociology and culture and communication. So that's been a huge take-home lesson. The modes of communication, I think, have been fascinating. I have taken to Twitter, which I think has been actually a very effective mode of communication. If you think about how we're all getting new information about this thing we knew nothing about 10 months ago, a lot of it is coming out through preprints. It's coming out through press releases. It's getting peer reviewed on Twitter. It's a totally new ecosystem from the one that we were all used to in the world of journals and peer review. And there are parts of it that are very exciting and parts of it that are, of course, challenging and potentially threatening. So another area that we have to pay a lot of attention to, but taking advantage of new modes of communication to get the word out. In the old world, in an academic place like mine, the currency would have been, you publish in a traditional journal and it gets peer reviewed, and that's what's on your CV, and that gets you promoted, and that's what gets you famous. And now I think that's an inadequate way of thinking about the world. If both professionals and patients are learning through social media or learning, watching conferences on YouTube, we need to be there too and do it in a way that people find interesting and acceptable. Because we're really competing for eyeballs and we're competing for attention against a lot of other ways of communicating that are potentially less scientifically based than ours are. I guess the final thing I'll say is one of the things I've been proudest of, and I don't think it was unique to UCSF, but I certainly saw it at UCSF, was a level of organizational nimbleness that was generally not, is not our daily diet at the University of California institution with 30,000 employees and spread across, a bazillion sites. And one of the most impressive pieces was the command center, which, I'd seen drawn up on all sorts of, plans for crises over the years, but to see it snap into action and become a form of healthcare martial law, but I would say benign healthcare martial law, where they really just took over and started making decisions and got past all of the flag flying and all of the bureaucracy and an old saying, what do they call a 99-to-1 vote of the medical staff? And the answer is a tie. There was just no time for any of that stuff. And it was really impressive. And obviously you can't operate like that all the time, but I think it demonstrates how nimble that we can be when we need to. And I hope that we keep a little bit of that spirit going forward and recognize there are a lot of things that we have to do quickly, and some of this is digital transformation, and some of this is dealing with disparities, and there are a whole lot of urgent issues that we have to apply some of the command center urgency to, rather than snapping back to our old bureaucratic ways.
That's great, Bob. In our last session, Andrew Ibrahim used the term that there seems to have been a lower threshold for innovation as well. So things that were ideas that just bubbled up in ways that I think would not probably have happened before, but lots to unpack there. How about you, Michael, from where you sit in this remarkable spot at Google and a huge role you've played in ensuring some good information gets out there around the pandemic, your reflections on how COVID has potentially changed the way you look at digital transformation going forward?
Yeah, it's been an amazing year. And, for me, I've been in Google for 3 years, but as you started off, I spent a lot longer than that working on quality and safety. And I think the thing that I learned this year, I think there are 3 or 4 things that I learned this year, but probably the number one thing is that healthcare doesn't have to wait 17 years for an innovation to diffuse. We saw things, Bob posted this amazing data about the percentage of visits that were done by video. And, and UCSF was a national leader in video visits before the pandemic and had, I think 2 or 3% of visits being done by video. And all of us across the country moved to where the majority of visits for a while were by video. And that's pretty amazing that happened. And we've seen that in kinds of care. We've seen that in the basic science. We've seen that in vaccine trials. We've seen things that normally we would think would play out over a decade, play out over weeks. And that should teach us a lot once we're out of a crisis about the way that as a profession and as a community, as an industry, we can act. And I think that's probably the most important thing to not lose track of, is that there are many pandemics, not just this one. The second thing that I think I have thought a lot about over the past year is that structure matters and structural barriers matter. We've seen this as racism has played out. We've seen this as structural determinants of health have played out. We've seen that as as the way that the payment model has played out, putting health systems really in crisis. We've seen this in interoperability and the lack thereof, and the inability to share data in a reliable way. I think that's the second thing, is that structural barriers are important. The third thing is that technology, and therefore technology companies, have a role to play. We're having this meeting because of a technology company, that it can happen. You know, at Google, we tried to lean in really hard to public health as the pandemic was unfolding, and I'm really proud of the way the company did that. I'll tell one piece of data that you know, YouTube is a video platform, and YouTube has more than 2 billion people a month who go to YouTube. And what our colleagues in YouTube did was to link to direct public health messaging actually on the YouTube homepage for a while. And when you search for COVID or coronavirus, these things are called info panels. And these linked to, if you're in the US, to the CDC, if you're in the UK, to the NHS, to the WHO and other places, directly to them. Those info panels have been viewed 300 billion times. There are only 7 billion people on the planet. And it's hard to think about that number, right? And so, you know, 1,000 seconds ago, like, we were already talking. 1 million seconds ago was about 12 days ago. 1 billion seconds ago, Reagan was president. 300 billion seconds ago is well before the dawn of recorded history. That's a big number. And so it's undoubtedly one of the times that public health messaging has been the most available to the human population. We're not the only company who's done that. A lot of technology companies have done that. I think we've also realized that we have the ability to create data and tools that let other people do amazing work. And so we've made anonymized mobility data available, which governments and public health agencies have used, and we've started to see researchers use. We worked with Apple to be able to enable digital exposure notification. We've seen the Swiss public health group start to publish on that, Oxford, others, where we're seeing good results. And we've most recently made available an anonymized search data set of sort of what people are interested in the pandemic that researchers can use. We've started seeing them be able to do that. And we did that because we saw that the information interest from our users, to a lot of people, that very quickly we saw interest in coronavirus surpass interest in news or recipes or movies or entertainment. It became one of the largest information needs on the planet. And again, we're not the only folks who've done that, but technology companies are able to enable other researchers. And the last piece, where I think medical specialty societies have a really important role to play, is this role of being credible, authentic, and authoritative communicators. Bob has done this amazingly well. Like, I get texts from my relatives like, do you know this Wachter guy? And I'll say, like, my family looks forward to these. And I feel reasonably well informed about that. But there's a reason 150,000 people follow Bob on Twitter. And if we have time later, I'd love for us to spend a little bit of time talking about how some of these algorithms work, because there's a real dearth of engaging, authoritative communication that is accessible and engaging to Americans and to folks around the world. So I think those are my 4 things.
Wow. That's remarkable. So many things to connect the dots on. I really struck, Nakela, when you talked about the cracks in the research infrastructure. As you hear what's sort of possible in this big data space, does it change the way you think about what research looks like going forward? Or even bringing in public health data that would have been, I think, in the past, just unimaginable to be able to bring into the traditional research realm? How does that change the view of where you sit at PCORI?
You know, it's really an interesting question, because one of the things that we are launching right now is a strategic planning process where we're trying to establish our national priorities for the future. And so we've begun talking with some of our advisory panels and other stakeholders, and to launch this kind of process while we're also learning from a pandemic, we're seeing an interesting interplay of some of the priorities that are coming to the fore, and the concept of what we understand about social determinants of health, some of the larger kind of ecosystem issues that are implications for the actual healthcare setting, and that intersection of the broader context of public health is really coming out in terms of thinking about how we integrate that into our research enterprise and research activities in a way that's different. There's also a real kind of emphasis on thinking about reusable research infrastructure and real world data that would allow us to respond more nimbly to some emerging priorities and things of that nature. And PCORI has had a longstanding investment in the Patient-Centered Outcomes Research Network, which is kind of a distributed network of networks, and allows us to focus a bit on trying to think about how we make the research process more efficient and more broadly applicable. And we found that in this response, this pandemic response, that infrastructure has been invaluable in so many ways, but that there were things we had to figure out how to make more timely due to the pace of and the dynamic nature in the pandemic, where we've created something called the investigators have created a COVID-19 common data model. But in order to do that on the backbone of PCORNet, we had to think about, how do we do this more rapidly? And they were able to quickly think about a way in which to refresh data on a weekly basis as compared to the multiple months it would take in the past. And so I think this concept of not just thinking about kind of the cracks in the research infrastructure, but what we can learn and what we've done right now that actually can be more sustainable down the line, as well as how we start to think about bringing other types of data together with our traditional kind of electronic health record data and other types of clinical data sets, I think are going to be really important, especially if we want to get at some of the issues around thinking about race and disparities in health and healthcare, and really trying to disentangle that variable of race in a way that helps us understand what's more of that sociodemographic component as compared to the component that may really be due to bias or systemic racism or structural racism in and of itself. So it's a great question. I think it's pretty complex, and there's some inroads we've seen, I think, even during the course of the pandemic, but I think certainly have opened our eyes to possibilities in terms of embedding this kind of transformation longer term.
Fascinating. We Kristen Bibbins-Domingo from UCSF with Bob did this extraordinary webinar with us this summer with Elsa Perez-Estable about disparities in COVID. And it was so amazing to think, she had this great slide that was the importance of place. Yeah. As a link to survival, just the ability to think about how you get those data. And it isn't really race as much as it is really understanding where you live, where you go to, where you go to school, where you get groceries or not get groceries. It takes on so much different meaning. Bob, from where you sit running an academic department, how has this changed the way you deliver care, or the way, the way you've transformed perhaps the way people use information in new and rapid ways?
I think one of the most exciting developments that has come out of the last 7 or 8 months is a much more robust use of dashboards and automatically updated, visually attractive and useful dashboards of the kind that Michael probably looks at 47 billion times a day, but only because he's at Google, because I'm sure he did not have them at Chicago, and I did not have them at UCSF. It's just not, we have been in all, there are many parts of our digital lives where we've seen what it can look like in our consumer world, and then we go into our healthcare world and we don't see that. But I think COVID forced us to say, what are the data elements that we really need to be monitoring minute to minute, day to day as clinicians and as policy and decision makers? And how can we tap into those data streams and present them to clinicians and leaders and patients sometimes in ways that are usable and visually attractive and actionable? And I think that's going to be a durable change. I think we now have had our expectations raised for, there's all this data. Part of the reasons people are so pissed at their electronic health records, you spend all of your time inputting data and you get so little useful information out of it. But I think we are entering an era where there's going to be more and more pressure, and I think more and more facility within healthcare delivery organizations to, whether it's they do it or third parties do it, to take those data and deliver it back to them in the form of useful intelligence. So we're doing all of that. And I think as we've broadened our lens as to what are the important data things that we're going to be following and we care about, disparities now is much, much higher on the list than it was before, which is somewhat shameful, but as the president says, it is what it is. And now, as we think about the measures that we're using to determine, are we doing a good job? I think disparity is now taking its proper seat front and center, along with the other traditional measures of safety and quality. Part of the challenge there, I find, is there are now so many things that we're measuring. I'm old enough to remember the early days of the patient safety movement, where that was the only thing. And then, okay, now we had to integrate quality and evidence-based practice. And okay, now we have to integrate, patient experience, and then ultimately clinician experience, and then equity. And it becomes difficult to juggle all of the balls. There's only so much time and resource. And so trying to balance all of these imperatives without cutting them all too thinly, I think is a big problem. I guess the final thing I'd say, and this gets to what Nakela was raising, is I still don't think that we're in a position where we're able to take advantage of the diversity of data sources. And part of this is, as I think Michael hinted at, the interoperability problem has not been solved. And so we increasingly have this world where we have what we can get out of the EHR, and that we know that Google has all this wonderful stuff, and Kinsa is measuring everybody's temperature, and an OpenTable can tell us what people are going to restaurants, and social determinants are being measured but they're all being measured in different places. And nobody has yet laid the golden spike to weave these together into one usable data set that then can be mined to deliver intelligence to patients or to clinicians or to health systems. And I haven't seen much in COVID that has accelerated the pace of that kind of linkage. And that's a disappointment to me.
Any reflections on that, Michael? Certainly that's the world you live in. I think a lot of us feel like we're awash in data, but not always awash in information. What's the role of the Googles, the Verilys, the others to kind of really start bringing those strands together? One of our webinars this summer specifically was folks with Verily talking about the potential of cloud-based computing, the potential of, for example, what the All of Us initiative, which obviously Dr. Cook knows a lot about, in terms of being able to take these disparate data sources and look at them differently. Are we getting any closer to maybe not always assuming everything will ultimately be interoperable in the EHR space, but maybe we can live at a different level to make some of that happen?
Yeah, it's a good question, and my answer is going to be unsatisfying. Is that it's mostly not a technical problem; it's a policy and governance problem. I do think that we've seen, with the information block rules and other work that's come out, I do think we've seen forward progress. But I also think that because of competing priorities in the health system, we've seen delays in that progress as well. And so I do think that that's directionally really important. And I also think it's a place where medical specialty societies have a really important voice, right? I mean, any of us who have, in my clinical practice for a long time was intensive care, and I think any of us who have cared for a patient where we're taking care of them, and a couple of days later, like the CD or DVD finally gets brought in from some other place, that then you go and find the machine that has the DVD drive, and then you load up the little PACS viewer and then look at it, and you're like, oh, that thing's been there for 4 years. We don't need to worry about it. All of us have experienced the actual direct harm of that, or any of us who have had a loved one who needed a second or a third opinion for cancer or for other complex disease and have tried to get all of their stuff together. I think we see the direct harm from that. And it's not just that we want to make insights or research, but it's that day by day people's care is being impacted. I do think that there are some technical advantages that exist now that didn't exist 5 years ago. And what are those? Those are the ability to have significantly large data that are stored in a safe way with hundreds of thousands of security engineers helping to protect them, and that have the ability to do very fast computation to make inference or discoveries. That didn't exist 5 or 10 years ago. And I do think that there are some advances in machine learning that will help us join some of those data sets together in ways that can help patients and researchers. But mostly, I think it's not a technical problem.
Interesting. Actually, Bob, in our prep call, you talked about, the incredible amount of data that's coming at your clinicians if people increasingly start sharing all their home-based digital information, and how, ultimately is that a place for AI or machine learning can be helpful as to not overwhelm your clinicians.
Yeah, I think that is sort of the next generation of tipping points. So the tipping point during COVID from a digital standpoint, I think, is unambiguously telemedicine. It just, there are things that have improved in various ways, but doesn't feel like AI has bypassed a type cycle in at least not yet. Telemedicine clearly has. But it's going to lead, I think it's going to accelerate the next tipping point, which is if a patient is not coming in to your primary care practice every 3 months, or your specialty practice every 3 months, and that used to be the place that you check their blood pressure, their glucose, their pulse ox, and their weight. Well, now you become utterly dependent on on those digital data feeds that they're getting every day when they check their blood pressure twice a day with a digital cuff, or their glucose 4 times a day, or their weight once a day, or you name it. And just like telemedicine 5 or 10 years ago, the problem is no longer a technical problem. The technical piece is fine, the sensors are fine. The problem now is partly an operational problem, which is sort of who's going to outfit your house with all of those gizmos and make it all work and fit together. There's no kind of Best Buy equivalent to the way you wire your home for entertainment yet. There will be. But the much more profound problem is that, okay, we've now wired someone's house, and their wrist is wired, and their, everything else is wired, and their underwear has sensors, and all that is now feasible. And every now and then I'll hear a talk about this, and the talk goes, and here's what's going to happen that's going to be wonderful. All of those data will come streaming continuously or semi-continuously to their primary care doctor, who will be grateful to see all of this information about his or her 1,600 patients. And my stock response is that is a world of which I am not familiar. The world I'm familiar with, let's say it's 102 here in California. If I send an email to my 400 primary care docs that's going to start happening this afternoon, all of them will quit by 5 o'clock this afternoon. So you cannot take that new capacity to collect, and whether it's patient reported outcomes and surveys they're filling out, or they're breathing into their iPhone, or their toilet is now wired and can check their urinal electrolytes. I don't care what it is. If that is then injected as a straight shot into the stream of a primary care doctor or a specialist, the system will break down in about 5 minutes. So we need a whole new layer of the healthcare system that we sometimes call care traffic controllers. That has to be some combination of AI and bots and coaches and data scientists and primary care docs and specialists and who knows what, to manage this and oversee it and deal with the signal to noise problems and deal with the malpractice issue, because people are not going to want data that if they miss something and a bad outcome happens, they get sued. It is a massively complex, I think it's a more complex problem than the initial imposition of the electronic health record, which also took us 20 years. So, and my fear is we're going to enable the digital data flows without enabling the capacity to manage all this stuff. And that will make the challenges that we've seen with the electronic health record implementation, which I think have been very real, seem like child's play. So we got to figure this out. And I don't know, Michael and his company may do it. There may be specific companies that are built just to do this. But some of the companies will do it and say, we can do this in orienting ourselves toward the consumer, because that's what we are. We're a consumer company. But there's got to be another part of it that then connects back to the existing healthcare system. Maybe 20 years from now, we'll all be disrupted and we'll go away. But I think for the foreseeable future, probably my clinical lifetime, it will be all this consumer stuff that gets collected in the house, but it's got to then connect to the patient's doctor and the patient's healthcare system. So this is a really, really hard problem.
It's really interesting. Nakela, from where you sit, I mean, some of those reams of data are a gift, right? Potentially for research. But, you know, as you look at comparative effectiveness, so we also look at the comparative effectiveness of how do we use, you know, the devices that bring these data forward, et cetera. Thoughts on that?
Yeah, and I was even going to add to Bob's comments that, you know, a comparative effectiveness research, I think, is just so critical in general to the pandemic response. Well, you know, we can think about it from the standpoint of new therapies and vaccines against COVID-19, but I think also understanding the impact of these adaptations to healthcare delivery and really understanding that increased uptake of telehealth and telemedicine and whether or not we are seeing improved outcomes or worsening of outcomes in certain scenarios, dependent on what's available. So in addition to thinking about that outfitting in the clinic and in the hospital setting, I think it's the outfitting for the patients and in the community, where we are really interested in understanding how this is actually affecting health outcomes. And so we've actually focused part of our response in terms of funding activities to with pandemic in mind around thinking about these adaptations in healthcare, and have funded opportunities to look at these enhancements in various specialty practices, like in heart failure clinics, where we funded a study comparing in-person and telemedicine to determine the outcomes of these visits for patients, as well as thinking about impact amongst socioeconomically vulnerable populations, and have funded some work in that space. And I really like to see some of these results come to fruition to help inform how we think about longer term adaptation and adoption of these types of kind of alternative ways of delivering care, as well as the fact that I think that some of the telehealth portfolio we funded over the past 10 years in general have taught us lessons that hopefully we can start to incorporate as we move forward. And we still don't know a lot about telehealth. We do know that when it's culturally tailored and maintains some form of human interaction, it seems to perform better than when it's not. But we don't know about the harms as a substitute for primary or urgent care visits. And we still have a lot that we don't know about the digital supports as it relates to telemedicine, and whether or not there are issues around maldiagnosis or errors, and or changes in prescription utilization, or even overprescribing in certain scenarios where we've actually worked really hard to curb overprescribing for antibiotics and things of that nature. And we see in this telehealth environment that some of that is sliding back. And so I think it just brings to kind of the fore the maintenance of some of the quality issues and other issues that have been struggles for us all along to think about in a new environment, and how do we implement that. And so I appreciate your comment around the importance of this type of research. The data is rich, and we're loving the opportunity to really take the opportunities to step back, say, what have we learned already? What are we gathering now that can inform where we go in a future way? But I think we've also taken the approach that there's a lot of unknown here, and it's important for us to really delineate that pretty clearly.
Absolutely. No, that's a great point. One of the things we talked about as well in our prep call was this question of, with so much information coming out and so much data out there, the sort of the potential issues of speed versus rigor in terms of how information flows. And, you know, Bob, you shared with us the remarkable reach, for example, of UCS Grand Rounds, and how that has changed, or how people are now using preprints in ways that we've never used before. What's your sense of how potentially people actually use research findings differently now? And will that change our paradigm going forward?
I think it's hard to say, because anything that's happening under COVID, you have to adjust for the unprecedented amount of interest in this, and the fact that as of 10 months ago, the world's knowledge about this was precisely zero. So I can't think of a parallel issue where there's such an intense need to know. I mean, our Grand Rounds, which used to be a traditionally sleepy affair of 60 or 70 people wandering into the room, lights down, PowerPoint, 50 minutes, and 2 minutes for questions, is now we put it on YouTube. So thank you, Michael. And each one gets 2,000 people watching live, 10 to 50,000 people watching afterwards on YouTube, more than 1 million visits. I think they've been wonderful, and I've learned a ton, but I think so much of that is around what the COVID generated, unbelievable, unprecedented amount of interest. But I think it is teaching us things. It's teaching us that different kinds of ways of providing content is better. I don't know that I'm ever going to go back to a 50-minute lecture with 5 minutes of question. I think it has to be more interactive. You have to be asking the question, not did you teach, but what did they learn? How did it change their thinking? How did it change behavior? You have to be more open to all of the disciplines that people need to learn about. And as I said, COVID has been sort of a real eye opener in that. It's not just medicine and science, it's much broader than that. So I think we've got to be much more creative about using all of these tools and channels to try to engage our learners, whether that's a medical student or a patient or a family member or a community. And I think the community piece is also very important. One of the things we've done that has been, I think, quite impressive has been a lot of studies in the Mission District in San Francisco, which is a Latinx district, traditionally fairly underserved. And we went in early to do a fair amount of testing there. And if we had gone in as, we are UCSF, we would have been, antibodies would have been created to us. As typically happens when academic people, blaze into communities saying, here's my NIH grant and here's my IRB. It doesn't work that way. And we went in very humble and met with the community leaders, and the community really owned the study. And that was the only way we could get it done. So I think recognizing the importance of community, academic, and community corporate partnerships in getting this work done has been humbling, and I think is really going to be an important lesson going forward.
It's really interesting. One of our webinars over the summer as well, we had Clyde Yancey, who wrote that extraordinary piece in JAMA on COVID-19 and disparities, and he talked about how they have recognized the need to move from the idea of community engagement to community investment. And how much that changes the dialogue with community. I think particularly when you're talking about communities who have been traditionally, where there's a lack of trust, where their health systems haven't always been honest players in providing services to all of them. So I think lots of opportunities there for us to think differently and have that. I do want to go back to this education paradigm. We had a couple amazing sessions yesterday about this, the virtual explosion of different ways to think about education. Daniel Kraft did this mind-blowing thing yesterday on AI and VR and what's possible. But Vinny Aurora talked about doing CME accredited tweet chats. I mean, things, again, we would not have thought about in the earlier days. And I just want to go back to Michael's comment earlier about the importance of an authentic voice and the role of the specialty societies here. And I'd love your thoughts about how you think education changes. How do specialty societies need to change to go along with how we get that rapid new research findings out the door, how we can maintain being a trusted source when there's so much else out there? Maybe, Michael, I'll start with you.
Yeah, let me say a little bit about the frame of how information works and sort of what shows up at the top of, I think, many social media groups, but certainly the way that YouTube works, because I think it's pretty instructive. And so what YouTube does is it has, they call it the 4 R's. So if content violates policies or is illegal, it gets removed is the first R. The second R is that lower quality content gets reduced in the queue, high quality authoritative voices get raised, and then creators get rewarded to let them continue to make great content for users. And so, but most of it is in that middle bucket of reduce or raise. And so it turns out that there are some areas where high quality authoritative voices on YouTube, or I assume on other platforms, aren't engaging to consumers and to people in the real world. And I think, if you go and watch many briefings by the CDC or by public health agencies, they're not engaging in the same way that a creator's work is engaged. And you see that in signals of how many people look at it and how much information gets taken out there. So even if there are algorithmic ways to help identify higher quality content that is from more authoritative sources, if it's not engaging, it doesn't work, right? Because the education it's about the learner, it's not about the teacher. And the same thing is true in communication. And so there are, it turns out, best practices to how do you help make content that is engaging to learners but it's still authoritative and correct. And so early in the pandemic, we saw examples of this. We would see, there would be a video by the WHO or the CDC, and it would get 5,000 views or 10,000 views. And there would be a video by a creator that covered the same content and was accurate and would get 20 million views, 50 million views. And so it's really important. And so one of the things specialist societies can do, and individual physicians and nurses and respiratory therapists and social workers can do, is to learn about this, about the best practices for how to make these sorts of things engaging. Because the impact of science on human health is not just how good the science is, it is who knows about it and who can change the way that they act because of the science.
Wow, that's powerful. Nakela, from where you sit, that obviously has a lot of implications for the way you disseminate research and how we receive it and how we can then bring it out. How does that change the way you think of what PCORI does in terms of bringing out new research, and maybe even broader than that? You spent obviously a long time at NIH as well. Yeah. What's the role of the research agencies to help us bring out these findings in ways that are engaging in different kinds of ways?
It just does hit squarely in some of the remit of the way we think about things at PCORI, not just as a evidence generator, but also that next step of taking those results to the finish line and really trying to encourage the uptake in practice, making results widely available to the public. And one of the things that we've really tried to do is innovate in how we cut the lag time between publication of useful results and implementation in clinical care, as well as providing results to the public writ large, and thinking about the opportunities to take findings, digest them, make them publicly available even before publication timelines may usually come about. And so cutting that time of making results and evidence publicly available, but also easily accessible is part of what we really consider part of our mission and purpose in terms of trying to help people make informed decisions. We also have, in many ways, thought about when we think about a dissemination and implementation platform, not just the investments that are traditional in terms of thinking about the academic researcher or the individuals that have conducted the study, but how do we engage with professional societies, with communities, and we have taken an approach to directly funding engagement awards that both allow for the preparation of communities and other groups in our patient-centered outcomes research, but also the dissemination and implementation of findings. And this is where some unique things have been thought about in terms of what we've heard from societies about what works for them and for the clinicians that are on the front line. And we've started to put together different types of products like evidence updates and evidence maps and visual utilization types of techniques. So evidence visualizations and things of that nature that seem to have, I think, some of that more engaging relationship to draw the user into understanding what the information and evidence is that's out there and how to use it in regular practice. And a lot of that is actually shaped and designed by those societies and those organizations that are helping us to think about the right ways of doing this for the uptake that we're looking for. So it's a work in progress in some ways. We've had some experience here and we're continuing to grow it. And we're fortunate that as part of our reauthorization for the next 10 years, that this has been an area that was called out as an emphasis for us to continue the efforts. And so I think now we have opportunities, hearing what Michael's talking about and Bob here, that, we can do things in a different digitally engaged way that will continue to kind of push forward that momentum on thinking about innovating and getting results out, how we do it earlier and faster, and how we get the reach that even goes beyond our traditional scientific, academic, and clinical communities to the greater public, building the trust that I think we were talking about before.
It's really interesting. Bob, yesterday, Vinnie Aurora, who you know well from hospital medicine, was one of the plenary speakers at our education panel. And she made the point that we don't really reward those in academia who bring this digital skill set to the table. Any thoughts in your world, chair of a department, you've been in academia forever. What does that mean? How do we bring these different skill sets to the table? And actually, who are the other key players we should be incorporating in as we think about moving to these new approaches?
Well, I think we are starting to reward this, and sometimes in a kind of circular way, in that maybe we don't reward that you're on Twitter or on Facebook, but we do reward that your papers are getting noticed and that you're being picked up, in the New York Times, which is increasingly is about what you're doing on social media. I mean, one of the things I've found is that the level of synergy and cross-fertilization between social media and traditional media is extremely high. A lot of reporters find their stories from reading social media. And if sometimes what they're reading on social media is a distillation of an academic paper. And so I've made the point with my faculty that, you don't have to do this, but if the goal here is impact, and it's hard to imagine what you're doing if that's not the goal, then you need to think about what are all the tools at your disposal to get the word out about what you're doing. And that ultimately, we simply have to change from the old paradigm that something like social media or writing or speaking to the lay public is a distraction. It's not what good academics do. If it's not what we do, then what the hell are we doing? I mean, we should be trying to influence people's thinking and their behavior. And so I've been encouraging my faculty to take advantage of forums like Twitter and Facebook and others to get the word out about their work, which I think I've seen more and more people do, and I think can have a really positive effect. You have to do it carefully. You have to do it respectfully. You've got to be super careful about HIPAA and all of those sort of things. I mean, one of the lines I find I have to walk is, and this is true in leadership as well. I really think, we're in an era where authenticity is really important. And so the idea of the old leader who is, up on a mountain and not accessible to the people in their world just doesn't work anymore. And so I see Twitter as a place where I try to be fairly authentic, but which means that sometimes I'm getting a little personal. Sometimes these days I'm getting a little political. And, I work in a big complex institution where you've got to be a little bit thoughtful about when you can and when you shouldn't be crossing lines. So these are tricky issues. They're things that are as worthy of learning as, learning how to make a diagnosis or learning how to write a paper or get a grant. And I think we have to increasingly emphasize that as part of the skill set of our trainees and of our, particularly of our young faculty.
Absolutely. Michael, any reflections there?
No, it's changed pretty fast, right? That, Bob and Vinny are both examples of folks who have had a lot of impact and changed a lot of lives through the use of social media. And so I do think that, before I left trying to get people promoted to, associate professor and other things, I do think the addition of things like altimetric and things have actually helped a little bit in places like that. But I do agree that I like the way that Bob phrased it of the point is impact on human health. And if no one ever knows about your research, it has very little impact.
Yeah, no, it really does change a lot. I got called by a New York Times reporter last week about masks because she read my health affairs blog. Things that probably would not have counted at Harvard as being a publication.
Yeah, it's a great example.
Like, oh, you read my blog on health affairs. Okay, interesting. I want to spend the last bit of time coming back to this question of how can digital transformation potentially help. We've talked a lot about COVID-19, but I think many would say we really have dual pandemics right now of COVID-19 and racism. And I'd love your thoughts about how we could potentially take advantage of this digital transformation of education and healthcare and research to really make an impact on structural racism in healthcare and the medical profession. Nakela, I'll start with you.
Well, I've been thinking about this as we've been talking further, and one of the things that has come up in some of our discussions is really kind of as in a research enterprise, how we think about a variable of race. And I think one of the key points that I've taken from a lot of discussions of recent is the importance of really deconstructing that variable, really understanding what it represents. And I think that's an opportunity for us to think about digital transformation and the way in which we study issues around race, and having the opportunity to tease apart where the social determinants are, where the geographical influences come to play, how we leverage data on where people live, work, play, et cetera, and bring that into a healthcare setting, and that kind of combination of information and data streams that we know will be challenging, but is where we probably need to go. And then there's another place where I actually think we may be able to see kind of a greater focus on bringing the digital transformation into thinking about issues of racism, and that's how race is used in algorithms in clinical care. And I think that that's a very debated topic in terms of understanding whether that can be beneficial or harmful in some scenarios, and really starting to dig to understand what that's about, I think is really critical to getting a sense as to whether or not those are useful ways for us to even set some sort of prediction algorithms or prediction rules, or use certain types of clinical scores to help inform what treatments or options we may choose for patients. And I think understanding the both benefits and harms there, and bringing a digital overlay into how we do that, could be quite informative. And the last piece I'd say is that when we really try to get down to what components of structural racism actually have implications for health and healthcare, I think that there are opportunities for us to think about how we gather information from patients and communities, how we engage patients and communities in that gathering of data, that actually will help inform whether or not we're seeing implications of structural racism in the types of things we're trying to address, eliminate, et cetera, whether it comes down to health outcomes, disparate outcomes, et cetera. And so maybe those are some of the areas that I would anticipate. We have huge windows of opportunity now if we can bring kind of thought streams together to tackle a very common problem.
I agree. Robert, Michael, any thoughts there?
Well, sort of a couple of things come to mind. One is, as soon as you talk about digital and disparities, you raise the issue of a digital divide, and will digital decrease disparities by providing more access to people that otherwise were limited in their access, or will increase disparities because of the complexity and the cost of getting the digital tools to who needs it. I think that's an open question that will be kind of empirically determined. You could see it doing both or neither. My hope is that as we have different kinds of payment models, the cost of outfitting everyone with the ability to have digital access to care will be low enough and lower than the cost of an ER visit, so that the system will be primed to make that happen. But that may be wishful thinking. And obviously the issue of bias and in the way algorithms play out is really important, as Nakela mentioned. I guess I see a couple of big buckets here. One is the issue of measurement. And as I hinted at before, one of the lessons from the patient safety and the quality movements were you had to begin by articulating the case, as the IOM reports did, and then figuring out what are you going to measure to determine how you're doing. And then you have to figure out what do you do with those measures, using them for transparency and comparative reporting. Are you using them for payment? There are all sorts of things that you can use with the measures. We have to sort of figure out what the measures are, and then elevate them in the orbits that we care about. And I think that's just starting to happen. I can envision a world where a health system or a physician is judged, not only did they provide evidence-based care for a given disorder, but is also judged on measures of health equity, whether it's processes or structure or outcomes. And I think that's very important, in the same way we haven't completely fixed safety and quality or patient experience with those measures. We certainly have moved the ball down the field by elevating them in measurement, and then the system kind of doing what it does with them, whether it's through transparency or through payment changes. The other thing that I think digital is going to be really important is, as I think about disparities, so much of it relates to social determinants. And I actually am quite fearful that all of that will be laid at the feet of the healthcare system to fix. I mean, the healthcare system can't fix housing, it can't fix education, it can't fix income disparities, it can't fix the justice system. Sometimes you hear about healthcare systems taking on building housing. And I always get worried about that, because we're not even that good at healthcare. The idea that we're going to go out there and become, fix housing, that's not going to work. So the only way to really address these disparities, to the extent that they relate to social determinants, is to take some of our funding, which is going to be tricky politically, and move it into other sectors, and then connect the dots so that we all know what each other's doing, and and connect the dots between the healthcare system and the communities. And that's got to be done digitally. Some of that has to be done in person, but a lot of that will be done through digital ways of communicating, digital data flows. Because it was it was much easier if we were just talking about how do we take care of a patient's heart attack. If you start talking about all of the social determinants, you've got to be out in the community, you've got to be measuring different things, and you have to connect all those dots together. And I think digital is going to be a very important part of that.
I agree. Michael, the last word. I know you've thought about this. Yeah. You've written about it with Marshall Chin and others. Last thoughts about how data can really help us with this, the issues of equity as we have this digital transformation in front of us.
Yeah, I would say three things really quickly since we're at the end of the hour. The first is that I do think the fact that we all carry a movie studio in our pocket and can make it globally available has made racism visible in ways that it wasn't visible before, and that has led to really important change. The second is that the attention to the digital divide, who has access to broadband, what are the data plans that people have on their phone, I think is really important to pay attention to. The fact that many of these devices are falling in cost has led many more products, but there are other things besides just the device. And the third, you're right, we did take the pretty unusual step of writing with Marshall Chen a paper in Annals of Internal Medicine about how to think about machine learning and health equity. And so the one thing I would say is machine learning becomes more and more available to everyone to use in their own research practice. If you don't think about these issues at the very beginning, then what will happen is your algorithm will find the disparities that are in the data and will just amplify them. And there are design choices you can make and technical approaches. And so that's a really important point.
Wow, that's a really good point. I think most people don't think about it all. Well, thank you all so much. This has been a great way to cap off a couple of long days, but great days of thinking about these questions. And we'll definitely share this back out with our societies because there's so much rich information here. And also thank you so much, Nakela, for PCORI's sponsorship of our meeting as well. I think there was a great opportunity to really think about how we get research out into practice. And thank you for giving us some really important ideas about where especially societies, especially working across specialties, can really make a difference. So with that, thank you so much. Have a wonderful, wonderful weekend. Thanks for all of our attendees for joining us, and have a great weekend, and be safe, everyone. Bye-bye.